So continuous renal replacement therapy is used for acute kidney injury in its most severe form, as well as for management of fluid overload in both children and adults who are not able to handle the fluid themselves, or if they have injury to the kidneys that precludes them from removing or from having acids removed from their body, they have electrolyte derangements. And there's been a lot of controversy around when to initiate CRRT, and there's been a number of randomized control trials conducted in adults. And some of them have demonstrated that an earlier start is beneficial to patients, and some have demonstrated that there's no difference between an early versus a delayed initiation. And that was most recently found by in a study called the START-AKI. So there's still some controversy among adult patients of when to initiate renal replacement therapy. This controversy extends to children as well, in that there's no prospective studies, and many of the studies that have been conducted in children are retrospective in design, as was ours, and I'll describe that more for you in a little bit. But the studies that have been done in children are largely single center, so from one center, small in number, and despite that, they do demonstrate a benefit in survival by earlier initiation. Each of these studies looked at their time to initiation in a little bit of a different fashion. So some used hours and some used days. But as our study found, the longer you wait to initiate renal replacement therapy, the worse your outcome was at 90 days. And we looked at a composite outcome of major adverse kidney events at 90 days, which is a composite of death, persistent kidney dysfunction, either defined by persistent elevation of creatinine or persistent need for dialysis. Yes, the study is retrospective in design because we really needed to get a handle of how centers are practicing or utilizing renal replacement therapy, and how practice may vary across institutions. So the intent was really to get as many centers as possible included, so we could have a better understanding. And this question came out of the development of this large collaborative that I run called WeRock. It's the Worldwide Exploration of Renal Replacement Outcomes Collaborative in Kidney Disease. And it's represented by 35 centers, pediatric centers from 9 countries around the world. And obviously there's different practice patterns in and around the world. And so having this data amongst these 969 children where we could quantify their outcomes and the effective timing to initiation was really important. We captured patients from 2015 to 2021, although the vast majority of the children and young adults were from 2018 to 2021. And we included patients who received CRRT for acute kidney injury or fluid overload as their primary indication. So we did not include those who would get CRRT for another indication. And some of those include inborn errors of metabolism and ingestions and things like that. And the children up to 20 or young adults up to 25 years were included as well, mostly because these are the types of patients that we care for at pediatric institutions within the United States. So we looked at this in a couple of different ways. The first was using a propensity score analysis, really focusing on the time to initiation. And what we see in this study, looking at the time to initiation in 2 different ways. So for every day that we delay initiation of renal replacement therapy, there's a 3% increase odds of major adverse kidney events at 90 days. Now, we looked at this in a different way as well, using an interquartile odds ratio. And I think this perhaps is a little more tangible tangible for the clinician. And so if we compare the upper quartile to the lower quartile, if you started renal replacement therapy on day 6, your risk of major adverse kidney events at 90 days was 21% higher than if you started renal replacement therapy on day 1. So I think, and then the second way we looked at it, or the other important finding, is that we looked at this also with a fluid metric of 10%, starting early and starting late, which we defined as greater than or equal to 2 days and then less than 2 days. And what we found is that the fluid metric really didn't matter, which is quite strikingly important, because I think intensivists have become very attuned to the bad or negative effects of fluid overload. And so they're not letting their patients get as fluid overloaded. But the major effect was really on the time to initiation and its impact on the outcome. So while this is retrospective, I think, we have large center data now to demonstrate that delaying initiation of renal replacement therapy is associated with worse outcomes. But obviously this cannot be ascribed to causal effect because of its retrospective design. And so I think this gives us some way to structure a prospective study in which similar to how they've done in adults, to really look at how and when we should initiate renal replacement therapy in children and young adults treated at pediatric hospitals. So I think clinicians should continue to focus on not delaying initiation of renal replacement therapy, especially when they have access to the tools available, and avoiding significant fluid overload, and really keeping the patient on track. And I think taking a deeper dive into some of this data through sub-analyses will potentially identify discrete populations that might differ. And so hopefully with that, we'll have additional information. But early initiation definitely seems to be an important start point for how we should consider changing our care in pediatric patients and moving forward.